let's dive into something today that kind of challenges a basic rule for many of us in endocrinology, using SGLT2 inhibitors in patients who have end-stage kidney disease. For years, right, this was a hard stop, a clear no. But what if the science is starting to tell us we've been missing a huge opportunity to protect some of our most vulnerable patients? Let's get into it. First, to really set the stage, let's just sit with this number for a second. 45%. That's how many deaths in the dialysis population are caused by cardiovascular disease. It's a staggering burden, and it's a huge red flag that what we're doing right now, well, it just isn't cutting it for these patients. So where does that leave us? Where do we find a better solution? What if the answer isn't some brand new exotic molecule, but a class of drugs you and I know like the back of our hand? And what if their biggest benefit in this situation has almost nothing to do with their name? We all know this story all too well. For our patients with end-stage kidney disease or ESKD, we throw our best conventional weapons at the problem. Statins, really aggressive blood pressure control, RAS blockade. And yet, the hard truth is that for our patients on dialysis, these tools just aren't powerful enough to dent that devastating cardiovascular risk. The needle just isn't moving. And that leads us to this core clinical rule we've all lived by for years. The dogma was simple, right? SGLT2 inhibitors work through the kidneys. So, when a patient's kidneys finally fail and they have to start dialysis, we stop the drug. It was logical. It was an open and shut case. Or so we thought. But that old logic is now being completely dismantled. The thinking used to be that the benefits were purely kidney dependent. No filtration, no effect. Done. The new emerging view is way more radical. What if the most important cardiovascular benefits are actually independent of the kidney? And look, this isn't just some fringe theory. In 2023, the FDA made a huge move. They removed dialysis as a contraindication from SGLT2I labels. That's a massive signal that the science has truly changed. Okay, so this just begs the most obvious question, right? If you take away their main job, the very reason we call them what we do, how in the world can these drugs possibly help a patient on dialysis? Well, the answer is pretty fascinating, and it lies in these mechanisms that we're only now really starting to understand. So the answer really comes in two parts. First, let's talk about the indirect benefits. These are advantages that are still kind of tied to kidney physiology, but in a way that is surprisingly relevant even for patients who are just starting dialysis. First off, there's that residual kidney function. Even when they start dialysis, many patients still have a little bit of function left. And we know that holding on to that precious bit of function is tied to better outcomes. SGLT2 inhibitors seem to help do just that. And then there's this really cool effect on anemia. Studies are showing they can actually boost hematocrit and cut down on the need for those erythropoietin-stimulating agents, the ESAs, probably because they're kicking the liver into making more erythropoietin. It's like a critical backup system when the kidneys are offline. But as important as those effects are, they really aren't the main event. The real breakthrough in our thinking here, the real paradigm shift, is that for this specific group of patients, the most powerful benefit of an SGLT2 inhibitor might have nothing to do with the kidneys. The main story is all about the heart. So let's get right to the heart of the matter, literally. We're now starting to uncover how these drugs are acting directly on cardiomyocytes, on the heart cells themselves, to provide this powerful cardioprotection that is completely independent of the kidneys. So how do they do it? The evidence is pointing to 4 key direct actions. First, they seem to inhibit the sodium-hydrogen exchanger, NHE1, right on the heart cells. That helps reduce toxic levels of sodium and calcium inside the cell. At the same time, they're quieting down the NLRP3 inflammasome, which is a major engine for cardiac inflammation. So you can think of it as this multi-pronged attack. They're improving the cell's internal cleanup crew through autophagy, while also dialing down the stress that causes cells to die in the first place. These are profound cardiac effects, and they're happening miles away from the kidney. Of course, these elegant mechanisms are one thing, but as clinicians, we're all thinking the same thing. This is great in a petri dish, but is it safe for our patients? And where is the hard clinical evidence to back it all up? The very first question any of us would ask is about safety. I mean, without the kidneys to clear the drug, does it just build up to toxic levels? Well, pharmacokinetic studies have given us a really reassuring answer. Even after a full week of daily dosing in dialysis patients, the research shows no significant drug accumulation. And that finding is a critical green light for this whole idea.
So, with that promising science in hand, this is all being put to the ultimate test. This isn't just lab research anymore. We're talking about major clinical trials that are happening right now. You've got large-scale outcome studies like Renal Life Cycles, which is looking at hard endpoints, all-cause mortality, heart failure hospitalizations in over 1,000 patients. The results from these trials are what will ultimately decide the future of this therapy. So, this all leads us to one provocative but very practical question. For a group of patients facing such incredibly high cardiovascular mortality, could an old friend, the SGLT2 inhibitor, become a new standard of care by working in a completely unexpected, heart-focused way? The evidence is building, and for our patients on dialysis, the answer could literally change everything. Thanks for joining us on The Explainer.